morning. Thank you, Jay, and thank you, AIS, for this opportunity. So, something which is flavor of the day and a case which has been troubling me even today. I saw this patient, so I wanted to just discuss about. This is a physician, one of the leading practitioners from eastern part of the country, Uttarakhand, and he complained of diminution of vision in both eyes. He suffered severe COVID disease for which he had been admitted, and he lost vision first in the left eye and then in the right eye. He's diabetic hypertensive. He complained of pneumonia, respiratory failure, high fever, hypoxia. RT-PCR was positive. He was admitted for 3 weeks, at which time he got a massive amount of IV antibiotics, antifungals, antivirals and steroids. And he was on NIV oxygen support. X-ray chest was typically suggestive of COVID-19 pneumonia. So left eye, he had some floaters at 1 day after discharge. And a week later, he presented to his primary ophthalmologist in the town of Kashipur, where he resides, and she diagnosed as a subretinal altered heme. So the initial diagnosis was wet AMD. And then 10 days later, he complained of vision in the other eye. So I'll just show you the picture. So basically what I want to emphasize is because he came with the right eye with this hemorrhage, it was thought that it was initially thought to be AMD. And when it became larger, then the doctor thought that because he had been on steroids for almost 50 days, and because they were withdrawing the steroids, the inflammation was starting. So he was started again on tablet Vizolone 40 mg, and periocular triamcinolone was injected in both eyes. So the total duration of steroids for COVID and vitritis was 50 days. So you can see this is the right eye with the hemorrhage, and the left eye, this was what initially came up and was thought to be subretinal heme. You can see in the middle also there's a red patch. So this was basically initially diagnosed as wet AMD. When the patient came to us, it was scary because this was a physician and he had totally lost vision, counting fingers 1 meter and in the right eye, and he was just counting fingers close to face, PR accurate in left eye. Pressures were okay, cells and flare in the AC, and a significant cataract. So this was the initial picture of both the eyes. You can see the right shade better, but you can see this yellowish white fluffy exudates in the right eye. You can see the disc clearly. The left eye is much worse. You can see that there are 3 lesions. There's one at the macula, one temporal, and one huge like a subretinal abscess inferotemporally, and the retinal vessels are going over this abscess. So when we saw this clinically, we diagnosed this as endophthalmitis, and we decided, so now first call I'd like to ask the panelists is, which eye would you treat first? Would you treat the right eye first or the left eye first?
Any thoughts?
I don't know. Both the eyes intravitreal voriconazole, because the picture does not look like a suspicion of fungal is pretty high.
I agree with Dr. Lalit Verma. Why not both eyes? I mean,
yeah. I don't think that, this is not a situation that we choose one eye or the other. Maybe alternate day, if not on the same day.
So, this is the rare indication of bilateral vitrectomy. Alexandra, any thoughts?
Well, I think it was interesting, because this patient obviously is immunocompromised. He's been on steroids for a long time. He's been in the hospital for a prolonged period of time. So I was just a little surprised to see that with such vitritis in the left eye, the thought initially that it was maybe AMD. I think the suspicion for this patient is extremely high. And I agree. I probably would tap and inject when, the day I see them, and then start planning for surgery. But I wouldn't even wait for surgery to tap and inject, as others have mentioned.
So initially,
this brings another question also. Has the COVID become negative before you started treating him, or was he still on COVID?
No, COVID is negative now.
Negative.
Yes.
So if the COVID, I have one patient. The reason why I asked is I have one patient who is recently turned COVID positive when he was planned for an endophthalmitis vitrectomy. So what's your thought process now about that? Do we have some protocols on that?
I think we should still go ahead and do with all the precautions, because people are still doing their emergency surgeries, and this is definitely an emergency surgery.
Yeah, Gopal, because this is an emergency, I don't think so. The line of management of vitrectomy would change with regard to RT-PCR.
So we did operate one eye, and at the same time I injected antifungals in the other eye. So this is the surgery of the right eye, which is the better eye. As you can see, this is a huge amount of exudates. And the interesting part is the abscess, which even when we remove the posterior hyaloid, you see a lot of the exudates come out, but that abscess remains at just below the macula. And so I think we can move on. And left eye, of course, was done just a few days after the right eye. This left eye was much more of a challenge because the lesions are much more extensive in the left eye. So you can
just a quick question. How many of you would be very comfortable in inducing PVD in patients with active endophthalmitis like this? Any thoughts, Raja?
Yeah, I would go ahead in this case, although it would be a very gentle and careful induction, but I would go ahead with PVD induction.
Okay.
By and large, I would also agree with Raja.
Yeah.
We try to induce PVD because especially if the predominant exudation is below that, so we should try.
And I just wanted to
visibility of what we are trying to do, and also the ease of the PVD coming up.
Yeah.
So we should not force it.
Don't be too dramatic. Yeah.
So I just wanted to bring Dr. Lalit Verma's. I remember, sir, you used to talk about using oil in endophthalmitis.
Yeah.
So I would request you a few comments about this.
I thought let us see this video, then I'll comment.
Okay. Yeah, please. We would love to hear that.
Sorry, at the posterior pole, there are some hemorrhages and this yellowish clump-like thing, which is becoming a scar. And then there are two separate masses. And if you can make out the inferotemporal one is really bulging out. It's like a large abscess. And then there are all these, what we feel are like fungal colonies, these fungal balls are there. And in this case, yes, very good, aptly brought up by Jay. This eye, I did use oil after doing a fluid air exchange in the left eye. So that is also something we could discuss. So right eye improved to 6/24. Left eye is counting fingers. Vitreous cavity is clear. The scar is forming in the right eye. And the left eye shows scar formation at the posterior pole with decrease in the size of the abscess in the inferotemporal quadrant. This is a post-op picture. Right eye, you can see, is doing quite well. This has become a small scar. Left eye, the posterior pole is scarring. The temporal lesion is becoming smaller. Inferotemporal one is really going down slowly. So I'd like to take the opinion of all my seniors and other colleagues about how to handle this eye. Just a quick look at the OCT, the pre-op OCT of the right eye. And you can see this mass. You can see these what we thought were fungal balls or exudates in the vitreous cavity and the attachment of the vitreous left. It's looking quite nice post-operatively, scarring down. And the left eye, this was the pre-op OCT, not very clear, but you can see this huge mass lesion, and slowly is coming down post-operatively. The patient grew candida on the blood agar plates, and these are the creamy white lesions. A gram stain showed the budding yeast cells, which are seen well. And thanks to the laboratory of Shankar Netralaya, we got a PCR which was positive. And when they did the PCR-based DNA sequencing, they also identified Candida albicans for this patient.
Yes, the right eye after vitrectomy, did you give voriconazole?
Yes, sir. So both eyes gave voriconazole.
No, post-operatively also, did you continue it?
So in the right eye, we gave it once post-operatively, but left eye now 6 times weekly. Every week I'm giving it, so it's been given 6 times. So right eye has had it at the time of surgery and once post-operatively, and is now seems to be doing well. But left eye, I'm continuing to giving the intravitreal voriconazole.
I'm sure this patient must be having oral voriconazole.
Yes, oral also is continuing, sir. Oral 200 milligram BD is continuing. Yeah. But how long should this go on? That's what is the longest anyone has treated this sort of things with voriconazole? And
actually, Candida responds very well to voriconazole. I mean, I say you are lucky that you got a Candida, not a like as this one other fungi, I would say rather. And generally, even their reports, they are giving even up to 3 months, continuing, because systemic medication, intraocular, I'm not talking about systemic medication. You can continue up to 3 months. Of course, you can keep on have your liver function test and your other parameters checked periodically. But voriconazole is fairly safe drug compared to amphotericin B and others. That is one. We had another case, what you saw left eye. It was not, of course, COVID era, but I think Muna operated that case. Intraoperatively, because of that huge mass, subretinal abscess, we decided to anyway overlying retina was a little bit necrotic. So just try to drain intraoperatively that single abscess. Okay, flatten on the table and put the oil in that case. Fortunately, patient is doing well, but extremely hesitant while doing that. If given option, I will be hesitant to create a break. Also, as Gopal said, easily PVD coming up, I would take out, but I will not force induce. But that case, it work out. Here, I think we just have to wait till that thing set up. Macula is okay now. So I think the peripheral abscess, you will have to continue systemic riconazole, and I think it will settle down.
Can I make a comment? Yeah. Can I make a comment? Yeah.
Yes, please.
I had similar cases of bilateral candida endophthalmitis following patients who are on dialysis and have a central line. They are increasingly predisposed to it because of the central line, and they develop this. So and very similar appearance of them, but they do settle down. I did get pretty good vision on them in both the eyes. They do respond. The abscess that you see peroperatively tends to come down, very well. I think because it's a very sensitive organism, it is very sensitive to antifungals.
Yeah, I would just like to share our experience at LV Prasad Institute. Great case, Daraius. I had one patient who actually presented with 20/20 vision, one just small subretinal abscess. I went in, just above that abscess, tried to take a biopsy sample, injected, started treating him, but in spite of that, he worsened under my care. But overall, what I would say is, we have now Dr. Samira Nayak, who is my colleague. She has collected about 33 eyes of 24 patients of COVID-19 presenting with endophthalmitis. And out of those, invariably, 80% of them have got fungus, and most of them were candida. Just a couple of them were aspergillus, and one was mucormycosis from paranasal sinuses. But the main thing is what Gopal asked, do they have an active COVID infection at that point of time? And if yes, they have a very high risk of mortality. 20% of our patients died. Now that's a huge number when you compare the overall mortality of COVID. So patients who are coming in an ambulance with the oxygen and they have this end of problem, they are at a very high risk of mortality because they are all immunosuppressed for various reasons. And if they are on steroids, they have to be stopped. But again, the COVID problem increases. But that's one thing which we need to be very much aware of. But if it's post-COVID, let's say beyond the recovery time, then the mortality is not there. But obviously, and only 50% of the eyes actually had less than 400 final visual acuity outcomes. So they all kind of go blind after this.
No,
Great.
Just last comment. We are getting short.
What I was saying was that it's a great management, what you have shown, Daraius. I would have also done the right eye first only, because that was the potential better eye and could have saved. And my indication of silicone oil, as Jay was pointing, was that I definitely induce a PVD and try to induce PVD in majority of the patients of endo. And without PVD induction, I would not inject silicone oil. So silicone oil does help to salvage a lot of these patients of severe endophthalmitis. And I have operated one of the COVID, fungal end of candida. And as was being pointed out by Pramod, you have to continue voriconazole for at least 2 3 months.
And one quick question, sir, when would you like to start topical steroids? Because the point is they have some cells flare and the pressure is going up in the right eye now. The pressure became about 30 in the good eye, the better eye. So it could be because of the inflammation, but we don't want to start too much steroid because of the fungus. So any guidelines on that?
Yeah. What I do is that once you have, once the patient is on antifungals, then topical low dose fluoromethalone drops, and more importance is for atropine actually. I do start.
Okay, thank you.
All right. I request to respond the questions on the chat because we are getting short of time. Let's move on. Thanks, Daraius. Thanks a lot for the fantastic case. And let's move on with macular surgery by a